This is Jeremy Woodward again from Cambridge, again a big thank you to the organisers for putting this meeting together under such difficult and strange circumstances, and for inviting me back to give another talk after my first foray into remote presentation. I must say I am missing the feedback and the questions and comments and suggestions from everybody, and I'm rather hoping that Heidi and her colleagues will find a way of getting that back to everybody so that we can share in the discussions that we're currently missing out on. So I'm going to be talking about refractory celiac disease now. And again, a really good place to start is with the Oslo definition, or Oslo 1 as I should call it, if hopefully if Jonas and Dave are picking up my hint from the previous talk that I gave. The definition of refractory celiac disease is fine, and it's a good starting point for us, although some of us may have an issue with the timescale, which seems unnecessarily restrictive in some cases, and also actually some of us might question the need for symptoms and signs, given that celiac disease at initial presentation, even with severe grades of villus atrophy, may be entirely asymptomatic, and we'll come back to that. So it was the Paris group, once again, that really opened the way for us to understand more about refractory celiac disease and are making significant advances in the biology of this condition. It was Christophe Sellier in the late 1990s that first published with the group on the identification of these aberrant intraepithelial lymphocytes that express cytoplasmic CD3, the T-cell marker, but are lacking in surface CD3 expression and also surface CD8 expression, which is usually expressed by the majority of T-cells present within the epithelium itself. On the left, this photomicrograph shows a section of intestine double immunostained, with the blue showing CD3. We can't differentiate intracellular from surface staining on immunohistochemistry, and therefore these cells are likely to contain cytoplasmic CD3 rather than surface. And as you can see, the brown stain for CD8 is absent in the majority of those in the epithelium. The relevance of the identification of these cells is that they appear very phenotypically very similar to those cells on the right, taken from a T-cell lymphoma, an enteropathy-associated T-cell lymphoma, which is, of course, the complication that is most feared with untreated celiac disease. And as confirmation that the refractory celiac disease aberrant lymphocytes present in the epithelium on the left are similar to those in the lymphoma to the right, is the similarity of T-cell receptor clones, this clonal rearrangement of the T-cell receptors, showing that these are a proliferating clonal population and effectively pre-lymphomatous. The importance of this is in the diagnosis of this condition of T-cell lymphoma, here seen on an endoscopic picture, and the really still ongoing very poor prognosis for this condition once diagnosed. It often presents at a late stage as well, but we're still seeing survival rates of only 20 to 30% at 2 to 3 years in many cases after diagnosis of this. If the finding of these abnormal lymphocytes present in refractory celiac disease can offer us an opportunity to diagnose this earlier, or perhaps find ways of avoiding it, then this is going to be a good thing for the management of our patients. So this identification of this aberrant population of intraepithelial lymphocytes, IELs, allowed the distinction of two different types of refractory celiac disease, labeled as type 1 and type 2. Type 1 is defined as not having this excess of aberrant lymphocytes present in the epithelium. And in fact, there are no defining features of type 1 refractory celiac disease from active celiac disease. Therefore, it can only be distinguished by taking a very careful dietary history and making sure that patients are excluding all gluten to the best of their ability. This will, of course, be very variable if this is the only way we can tell that patients with ongoing changes and symptoms do not have type 1 refractory celiac disease. And it'll depend very much on cultural considerations, how easy it is in the community to be gluten-free. That will differ between different countries and even different regions, and also perhaps the quality of the support and the service they get to be gluten-free. We biopsy all of our patients at a year after starting a gluten-free diet, and we have many patients in our cohort who have ongoing severe degrees of villus atrophy lasting many years, clearly not slow responders, but who are effectively asymptomatic to the best of their and our knowledge, but only in this type 1 group. We know very little about the biology of type 1 refractory celiac disease because we have no very clear ways of distinguishing it, and there are no unique features for type 1 refractory celiac disease compared to active celiac disease. It's a possibility, though, that it might represent a high sensitivity of the individual to very small amounts of gluten which are impossible to exclude from the diet. And if you like, this may be the genetic converse of what I spoke about in the first talk on potential celiac disease, who might have a sort of form frust with a very low immunological mutation burden, if you like, leading to a partial expression of the disease. This might be a very high sensitivity and at the other end of the scale of that genetic sensitivity, perhaps. When we come to type 2 refractory celiac disease, we consider this to be pre-lymphomatous. As I'll show you in a moment, a large proportion of patients either have T-cell lymphoma, this enteropathy-associated T-cell lymphoma, or go on to develop it. The presence of these aberrant IELs distinguishes them from both type 1 refractory celiac disease and patients who have active celiac disease. However, these aberrant IELs are present in normal non-celiac patients and also in patients with active celiac disease, although in reduced numbers, as I'll show you. And therefore, we have to apply cutoffs numerically, which are 20% on flow cytometry, or we've just worked out about 40% on double immunostained histochemistry. These cells also demonstrate a clonal proliferation. I would counsel against using T-cell receptor clonality as a means of diagnosing type 2 refractory celiac disease. Work done by many, including Liz Swire from the department here in Cambridge, has shown that often what we think are clones are not clones, but very closely related CDR3s that can't be separated. And of course, the background clonality is oligoclonal in the epithelium lymphocyte population anyway. And we and others have identified many patients who have clonal proliferation of T-cell receptors, positive T-cells, in normal active celiacs as a transient phenomenon, which then resolves over time with resolution of the histological changes. So clonal proliferation by itself is not an indicator of type 2 refractory celiac disease. Again, thanks to the ability to distinguish this as a separate entity, people working on the condition have come to understand a lot about the underlying biology of this and how the replication controls are lost. And it may be that this represents the effects of prolonged inflammation and exposure to gluten. This would be in keeping with the fact that type 2 refractory celiac disease and the lymphoma tend to present at a later stage, often in people who are diagnosed with celiac disease for the first time at the same time as well, suggesting they may have had it all their lives, and this prolonged inflammation and gluten exposure leads to this loss of growth control in the lymphocyte population in the epithelium. This also then leads to the possibility that type 1 refractory celiac disease could lead to type 2 refractory celiac disease, and we'll come back to that possibility. This is how we diagnose refractory celiac disease in our center using flow cytometry. In each of these plots, each dot represents an individual cell, and you can see that along the x-axis we have cytoplasmic CD3 staining. On the y-axis it's surface CD3 staining. This aberrant group of population of lymphocytes are those that lack surface CD3, but have the cytoplasmic CD3 and are therefore colored orange in these plots. And on the left is an individual with type 2 refractory celiac disease diagnosed in our center last year. And on the right is a normal non-celiac individual. And you can see, as I said, that these aberrant lymphocytes are present in under 20% of the lymphocytes that are separated in a normal individual. And that's why we have this cutoff to be able to diagnose the condition. If we compare that with the active celiac here on the left, this is indistinguishable from type 1 refractory celiac disease. And interestingly, here you can see that the proportion of both the CD3 negative cells in green and those aberrant IELs in orange are significantly reduced. This is in keeping with the lymphogram and the high numbers of CD3 positive cells that I showed you on those charts in my first talk on potential celiac disease as a means of diagnosing celiac disease in people, even if they are on a gluten-free diet with normal biopsies. In terms of the natural history of the progression of refractory celiac disease, our study here from 2013 is, I think, the only one that has attempted to look at the natural history prior to the diagnosis of type 2 refractory celiac disease or lymphoma. Hongzhang Liu, the first author on this paper, looked back with double immunostaining for CD3 and CD8 on biopsies taken from individuals archived from before their diagnosis of those conditions, and also carried out molecular studies for T-cell receptor clonality. These are the cutoffs that we identified for the diagnosis of type 2 refractory celiac disease, and also noticed a higher cutoff for those who had a T-cell lymphoma at that time. But one of the key findings here was that T-cell receptor clonality could be transient in up to 8% of those patients who didn't have refractory celiac disease. So again, not a useful test in the diagnosis of type 2 refractory celiac disease. These aberrant IELs appear to increase over time. We were able to see this by looking at sequential biopsies. And of course, we could only use immunostains because you need fresh biopsies for flow cytometry. This is the rate of increase we saw in those patients who went on to develop refractory celiac disease. As I've said, a higher proportion of these refractory IELs was indicative of coincident lymphoma, not just type 2 refractory celiac disease. And we think that perhaps 8 out of 10 of these refractory celiac disease type 2s progressed through type 1 with uncontrolled ongoing changes prior to developing this high population of aberrant lymphocytes. So this is one of the reasons why we keep a close eye on our type 1 refractory celiac disease patients. After the diagnosis of refractory celiac disease, this is the natural history, which is much better described. This is the data from the Paris group, showing really worrying statistics for 5-year survival and development of lymphoma. And this is mirrored by the outcomes from Holland and also from the USA. The dotted line at the top in the graph represents the patients with type 1 refractory celiac disease, which is also rather higher than we might expect from patients just with active celiac disease, perhaps. In terms of the question whether you should be worried about refractory celiac disease, the answer has to be that it is an extremely rare condition, and therefore on those grounds one should not be overtly worried if one is a celiac patient. This is the data from Austria, published in 2017, showing that they only had 7 type 2 refractory celiac disease patients over 24 years, 1 every 3 years or so. I find it quite useful to look at the ratio of type 1 to type 2 refractory celiac disease. A ratio of around 2 to 1 would suggest that people are not overdiagnosing type 1 refractory celiac disease on the basis of poor dietary compliance. The graph on the right shows the changes over time as far as can be ascertained, and it would suggest that not only is it rare, but becoming rarer, which is good news and even less to worry about. And similarly, this is the data from Holland, showing again the similar ratio of type 1 to type 2 refractory patients. And here 13 in 6 years in a national referral centre, about 1 in 3 million population per year. So an exceptionally rare condition, the type 2 refractory celiac disease. In terms of therapeutic options, I won't dwell on these as they're somewhat limited at the moment. First of all, rigorous antigen exclusion must be the mainstay for both type 1 and type 2 at the moment, to prevent any further activity. Steroids are a reasonable first line for both type 1 and type 2, but of course we would have concerns about the possibility of malabsorption and low bone density, and therefore systemic steroids probably best avoided, and using budesonide, perhaps open capsules, so there's better topical activity in the proximal intestine. Azathioprine is available and useful in patients with type 1 refractory celiac disease as a steroid-sparing agent, and can be enormously beneficial for some of these patients. We would advise avoiding it in type 2 refractory celiac disease, where another purine analog, cladribine, has been used. There is a hint that azathioprine might increase the rate of or risk of progression to lymphoma in type 2 refractory celiac disease. Finally, for those who have not responded to cladribine, the option of autologous stem cell transplantation is there. Relatively small numbers of patients have undergone this, and disappointingly, I think to date 3 of them have developed lymphoma after the stem cell transplant. Not the perhaps the hoped for treatment. Finally, we have results now from the anti-IL-15 Amgen 714 trial, which did not show a significant benefit for this group of patients, except perhaps some symptomatic relief. Future trials will be looking at combinations of anti-IL-15 treatment and other inhibitors that have been identified on grounds of biological plausibility, largely from the work of the Paris group. However, I think the dangers of refractory celiac disease are much greater than those of developing lymphoma. Firstly, there's the lack of recognition of this. It would be so useful if we could identify people at an earlier stage, before they develop lymphoma, or at a stage when they are getting lymphoma, where we could treat them better and earlier. This leads us to worry about the late diagnosis of both refractory celiac disease and also the lymphoma. I think probably affecting a larger group of patients is this risk of overdiagnosis. People who are relying on T-cell receptor clonality for a diagnosis of type 2 refractory celiac disease, and also people who are perhaps not stringently excluding the possibility of gluten ingestion in their patients and labeling them as type 1 refractory celiac disease, or even type 2 perhaps. And with greater information being available and greater awareness, the worry is that actually this is what we're going to be hitting first of all in terms of problems with refractory celiac disease, and having more worried patients and overdiagnosed patients, and actually overtreated patients who are on immunosuppressants such as azathioprine when they don't even have refractory celiac disease. And I think the likelihood is that this is a much bigger danger. I think the medical profession are probably more dangerous than the condition itself at the moment, until we have better understanding and better information available for people. With this in mind, and somewhat belatedly, in the UK, we've now set up a national referral service. The first rare disease collaborative network to be established by NHS England was in refractory celiac disease, recognizing the rarity of this condition and the need for a small number of centres to be able to collate cases and collaborate. And the first 2 centres that have been set up are ourselves and Sheffield. Our aims are really to disseminate and share information about refractory celiac disease, and to collaborate with colleagues who also have an interest in this around the country, developing information and also meetings to be able to support this. We need a reference clinical service, and we are setting up uniform diagnostic techniques between our centres, but also to be able to use for diagnosis uniformly across the UK. And importantly, to develop a national registry of type 1 and 2 refractory celiac cases that we can then use to recruit into international clinical trials of treatment. Given that these patients are so rare, we really need to be making sure that we study potential therapeutic avenues as well as possible. In Cambridge, our pathway is, when we're referred patients, if they're well enough to come as an outpatient, is a one-stop outpatient visit. This involves a full history and dietetic assessment with blood tests. And then we take, at the same time, a gastroscopy and duodenal biopsies, which we send for immunohistochemistry, flow cytometry, and standard histology. The flow cytometry is really useful because we get next day results with that. We're seeing many patients now who are being overdiagnosed with type 2 refractory celiac disease by their referring centres on the basis of T-cell receptor clonality, which seems to be widely available. And this now, because of the greater awareness of this condition amongst patients, is one of their main concerns, that they might have type 2 refractory celiac disease. So just after one visit the next day, I can usually phone them and tell them that it isn't. Of course, if it is, that leads to investigations then to look for coincident lymphoma at the same time, which need to be exhaustive because these things can be quite difficult to pick up. And if they have type 1 refractory celiac disease, then we'd go down a pathway like this, but with annual visit and flow cytometry on an annual visit with biopsies in view of what I've just told you about the possibility of progression, although we haven't seen this in any of ours that we're following up to date. This is a map showing the geographical distribution of the cases referred into Cambridge. The purple dots represent those with lymphoma or lymphoma-like conditions such as type 2 refractory celiac disease. And clearly we're right at the beginning of this, we're in the early stages, and I'm hoping that we will see referrals more uniformly across the country, unless it is that they're all going up to Sheffield, and we'll find out about that when we have our get-together in June, hopefully, as long as that's not put off by COVID. So I'm just going to finish now with 3 case histories that we've had here in Cambridge over the last year, just to demonstrate some of my concerns about refractory celiac disease. The first case is of what I would consider a delayed referral or a lack of recognition of the possibility of this condition. This was a fit 56-year-old man who developed abdominal pain, diarrhea, and weight loss shortly after a 2-week business trip that he'd been to West Africa for back in June 2018. There was a strong family history of celiac disease. In fact, his sister had seronegative celiac disease. His investigation showed normal colonoscopy and colonic biopsies, but duodenal biopsies showed subtotal villus atrophy. He was negative for tissue transglutaminase antibody and EMA, but he did have the compatible HLA DQ2. Because he'd been to West Africa, I think the line of thought was that this was going to be a tropical disease rather than celiac in view of the family history, although presumably it could have gone either way at that stage. And he was referred down to London to the School of Hygiene and Tropical Medicine, where they started him on empirical treatment, which he didn't respond to, but he's a somewhat uncomplaining chap. And in fact, it took him a long time to point out that he still had ongoing symptoms and significant weight loss. So a year after his initial presentation, an MRI scan showed that he had a 9 centimeters long, thick-walled segment of ileum. And at that stage, he was actually referred to me, but not for the consideration of the possibility of refractory celiac disease and lymphoma, but instead because we have enteroscopy and might be able to access this for biopsy. I have to say, having heard the story and received the referral, I got on the phone to him straight away and brought him up for gastroscopy the next day, not enteroscopy. Given what I've shown you, we only needed duodenal biopsies for flow cytometry to make the diagnosis. And here it is. This is very characteristic on the flow plot of type 2 refractory celiac disease, with this large population in orange of the refractory intraepithelial lymphocytes. So he went on, he'd lost a lot of weight, and so we set him up on home parenteral nutrition about 2 weeks later as an inpatient, and then he went straight to surgery for laparotomy and resection of this T-cell lymphoma, purely on the grounds of the flow cytometry. We didn't have biopsies of the lesion itself, but it did, of course, prove to be a T-cell lymphoma. And he underwent chemotherapy, and I'm glad to say went into remission on PET-CT at the end of last year, and has now undergone autologous stem cell transplant here just a couple of weeks ago. So this is one case really where I think we've perhaps had a delay of around a year in making this diagnosis. I suspect that he probably had lymphoma at the time, but it may be that we could have caught him at a time when he just had type 2 refractory coeliac disease initially. The second case is, I think, altogether more worrying. This was a fit 37-year-old woman who presented in 2013 with diarrhea and weight loss. She had a positive, strongly positive TTG antibody, and she had subtotal villus atrophy on her duodenal biopsies. She was appropriately diagnosed with celiac disease and treated and started on a gluten-free diet. In 2016, she had ongoing mild symptoms and so underwent further biopsies which showed ongoing villus atrophy. At this stage, her consultant gastroenterologist diagnosed her with refractory coeliac disease. He prescribed steroids and azathioprine and went to great lengths to try and persuade this young woman to take these. These are some of the comments from the correspondence. As you can see, he spent over 18 months trying to persuade her to take azathioprine and steroids. It says she's completely aware that untreated celiac disease exposes a patient to premature metabolic bone disease, small bowel lymphoma, esophageal cancer, gastric cancer, adenocarcinoma of the small intestine, and colorectal carcinoma. So clearly employing scare tactics here to try and get her to take the immunosuppression. He also said in a later letter that she's frightened about taking medication, frightened about adverse events, and has not yet appreciated that the small risks that she takes with immunosuppression are enormously offset by the benefits to her long-term health. She's an intelligent woman, and I think that a few weeks of thinking about what I've discussed today will put her in the right frame of mind to start immunosuppression. Well, I have to say, she is an intelligent woman, and she asked for a second opinion. Within minutes of talking to her, it was clear that there was a significant issue with contamination. She had a shared kitchen, and she was also eating many foods that may contain labels. So instead of going down our usual pathway at this stage, I simply gave advice and put off her rebiopsy for a further 9 months, which of course was entirely normal with no evidence of villus atrophy or inflammation. Immunohistochemistry is normal, and flow cytometry just confirmed, as we know, the celiac changes that don't go away when you're on a gluten-free diet. So entirely normal, managing the diet now well, 9 months after initial referral, and therefore discharged with no further follow-up. Certainly didn't have refractory coeliac disease, and I really worry about what would have happened to her had she spent years on immunosuppressants. The last case has been something of a revelation and a learning experience for me. This is a 51-year-old lady who had a history of mild rheumatoid disease and had taken methotrexate at some stage in the past. She was diagnosed as celiac in 2017. She had diarrhea and weight loss. She had villus atrophy, but her antibody was negative, but she did have compatible HLA. She was referred to Cambridge 2 years later because she had ongoing symptoms and ongoing villus atrophy on her duodenal biopsies. Biopsies were reported as showing this villus atrophy, but surprisingly with very low intraepithelial lymphocyte numbers. These are the biopsies here, and you can see the suboptimal orientation, but a significant increase in inflammatory cells in the lamina propria and a hint at least of significant villus atrophy. On the CD3 stain, as I say, this will pick up both surface and cytoplasmic CD3. You can see probably in the middle on the right slide, to the right-hand side, there's epithelium there with large numbers of intraepithelial lymphocytes, actually, staining with CD3, we can't tell whether that's surface or cytoplasmic. However, if you look on the CD8 immunostain here, you can see that very few of these cells actually have CD8. This lady also had a clonal proliferation demonstrated on molecular analysis of her T-cell receptor rearrangements, and therefore this would fit entirely with a diagnosis of type 2 refractory celiac disease by all of our current existing diagnostic categories. However, this was her flow cytometry pattern, and this is not characteristic of what we would see with type 2 refractory celiac disease. We only have 10.5% here in the aberrant IL group, and in fact that's more than we would see in somebody who actually has celiac disease. So this flow cytometry is that of a normal individual, a non-celiac, and also not somebody with type 2 refractory celiac disease, as we might expect from the histology and the immunohistochemistry and the T-cell receptor clonality. Looking at these cells in a bit more detail, you can see on the left, where we're looking at CD8 and CD4 populations, that the majority of these are atypically CD4 positive cells in the epithelium, and they're all bearing the alpha-beta type of T-cell receptor rather than the gamma-delta receptor. On immunohistochemistry for CD4, which we didn't used to do routinely on all our cases, but now do, you can see that the remaining cells in the epithelium are actually CD4 positive, and actually have some fairly atypical characteristics according to our lymphoma specialists. So this probably fits with an entity which is poorly defined at the moment of an indolent intestinal CD4 T-cell lymphoma. There's only 23 cases reported in the literature that I could find, but I suspect this is more common than we think because we've already seen 3 cases in Cambridge just over the last year and a half. And of course, it does necessitate CD4 immunostaining and flow cytometry, or else we would not have made the wrong diagnosis in this case and labeled this lady as having type 2 refractory celiac disease. The appearances are that this can be indolent and inconsequential in terms of symptoms for long periods of time, but it may transform into a more severe lymphoma. In fact, one of our cases did exactly that and transformed into a T-cell lymphoma. But otherwise, it does appear that it can actually have a very prolonged course with minimal symptoms or risk of progression. As I say, we don't understand this particularly well at the moment. Interestingly, in the cases reported in the literature, some have celiac disease and some don't. And this lady, in our case, may well not have celiac disease on the basis of the flow cytometry. So in summary, with regard to refractory celiac disease and whether our patients should be worried, I would say that it's potentially, yes, serious, but it's extremely rare and probably getting rarer as well. And that might relate to the efforts to maintain and support people on a gluten-free diet. There are significant dangers of misinformation, misunderstanding, and overtreatment, as I've demonstrated. The need for the reference network and registry was recognized in 2019, and I'm hoping this will prove fruitful, and I'm looking forward to collaborating with colleagues all around the country in this. Finally, in Cambridge, we're already exploring, as a result of establishing this network, new entities of enteropathy, as I've just shown you. And we're developing new diagnostic tools, particularly with Liz Swire looking at analysis of T-cell receptor clonality in our labs here. And new treatment options are becoming available, which will hopefully be in a position to be trialed in our patients identified through the network before too long. Thank you for listening.